Hello friends, in this video we will talk about reactive arthritis. What is this reactive arthritis? Reactive arthritis is acute non-purulent arthritis complicating an infection elsewhere in the body. Okay, so first there will be infection, after that this reactive arthritis develops. So elsewhere in the body, where else is this infection can happen? Infection can happen in the GI system, enteric infection. It can happen in genitourinary system, that is urethritis and all, or rarely you can have URTI, that is respiratory tract infection. Okay, let's look at this etiology and pathogenesis. So what happens there is, first there will be antecedent infection, like 1 to 4 weeks before this formation of or development of arthritis. There will be antecedent infection. It could be GI, that is enteric infection, like salmonella, most common, and all the species of Shigella, most commonly Shigella flexneri and soni, and genitourinary infections mainly caused by chlamydia trachomatis will cause this reactive arthritis in a genetically predisposed patient, like HLA-B27, like HLA-B27 positive or ERAP positive patients. Okay, so what happens after 1 to 4 weeks? So after 1 to 4 weeks there will be development of signs and symptoms of reactive arthritis, which I will be discussing further. So after 3 months or within 3 months there will be resolution. So if resolution doesn't happen, so symptoms may persist for more than 6 months. We label that condition as chronic reactive arthritis. The chronic reactive arthritis, this chronicity is because of the predisposition, like this genetic predisposition because of HLA-B27 positivity and ERAP1 positivity. So this is about etiology. So what is about epidemiology? So it is more common in males compared to females in genitourinary causing reactive arthritis. In enteric reactive arthritis, incidence is equal, 1:1. So it's most commonly in 18 to 40 years of age, and these 50% of reactive arthritis patients will have HLA-B27. So that's about epidemiology. Let's look at these clinical features. Clinical features of reactive arthritis can be divided into articular and extra-articular symptoms and signs. So what are these articular signs and symptoms? So it presents as acute, every word is important here, acute, asymmetrical, additive, not sequential, additive, oligoarthritis. As you all know, oligoarthritis means involvement of up to 5 joints, 2 to 5 joints. More than 5 is poly. With enthesitis and dactylitis. Dactylitis is nothing but sausage shaped fingers or toes. Okay, this arthritis is non-purulent. First it is non-purulent, and it's more common in lower limb than the upper limb. Okay, but it is inflammatory, non-purulent, affecting more in the lower limb than in the upper limb. So what upper limb, lower limb, what are the joints involved? That is knee, ankle, okay, tarsal and metatarsal joints. Okay, that is about arthritis. Sacroiliitis also, asymmetrical sacroiliitis, more asymmetrical than the ankylosing spondylitis. So extra-articular manifestations includes your keratoderma blenneragicum. What is this keratoderma blenneragicum? It is hyperkeratotic lesions. First, initially it starts as vesicles and pustules which ruptures and forms crusting, finally resulting in hyperkeratosis and causing keratoderma blenneragicum. It's more commonly affecting the palms and soles, but it can be seen elsewhere in the body also. More commonly palms and soles. I will show the picture later. So what are the nail changes? Nail changes, onycholysis can happen, distal yellowish discoloration can happen, and pitting can happen, and heaped up keratosis. This pitting can be seen in psoriatic arthritis, also one of the differential diagnoses of reactive arthritis. Okay, and there will be succinate balanitis in the glans penis. Succinate balanitis means circular forms of inflammation are seen in over the glands. And don't forget to mention constitutional symptoms like fever, malaise, and weight loss. So that is about signs and symptoms of reactive arthritis, articular and extra-articular. What about this? Ocular. I didn't mention here ocular. Sorry. Ocular manifestations includes uveitis. Okay. Then diagnosis. How to diagnose this condition? Patients will present with classical arthritis like acute asymmetric mono or oligoarthritis, mainly affecting the lower limb. This has to be there. So whenever patient comes with like this, like acute asymmetric mono or oligoarthritis affecting lower limb, with history of, there has to be history of preceding infection. Like what is this? I already told enteric and genitourinary, right? So enteritis. So that is at least 1 day of diarrhea, 3 days to 6 weeks prior to the onset of symptoms. That has to be there. Or at least 1 day of urethritis, 1 day of signs and symptoms of urethritis, 3 days to 6 weeks prior to the infection, plus the relevance evidence of the infection. Like if it is enteric infection, you have to have stool culture. If it is genitourinary infection, you have to have PCR for the chlamydia, positive PCR for the chlamydia. So additionally, your lab values will show increased ESR, mild anemia. Okay, you can get one PCR for chlamydia in cases of preceding urethritis, and radiological evidence shows in mild cases or early cases juxta-articular osteoporosis, and in long-standing cases asymmetrical sacroiliitis will happen, and syndesmophytes also will happen, spur formation and all. So before going to treatment aspects, let me show you the clinical pictures here. So look at this. What happened? These fingers are normal, but what happened to this middle finger? This is swollen, in sausage shaped finger. This is called a sausage shaped finger. Technical term is dactylitis. So this is only that infection of the finger, swelling of the finger. Okay, dactylitis. And see what I was telling about that hyperkeratoid lesion is keratoderma. This is keratoderma blenorhizicum. You can remember keratoderma blenorhizicum. It is nothing but hyperkeratosis of the palms and soles. Here it is sole. Then this is about enthesitis. Look at this tendon, Achilles tendon. This is normal. This looks normal. What happened to this area? It is red and swollen. So that is called as enthesitis. So these are about clinical pictures of the reactive arthritis. Now let's focus on the treatment. When patients comes with acute over 1 to 2 weeks acute symptoms, we have to treat them with high doses of NSAIDs like indomethacin 50 mg 3 to 4 times daily, or 75 to 150 mg per day. You can also use diclofenac 50 mg per 3 times daily. Okay, naproxen 500 mg by 2 to 3 times daily you can use. So after 2 weeks usage of 2 or more NSAIDs, okay, if there is no response to NSAIDs, then you can use glucocorticosteroids, or if the patient is having more than 6 months of symptoms, that time you will label it as chronic, and you have to use sulfasalazine. Dose of sulfasalazine is up to 3 grams, 2 to 3 grams per day you can use. Okay, so in refractory cases, when these two above treatments are not effective, or patient is not responding to NSAIDs and sulfasalazine, we label it as refractory. So that time you have to use azathioprine or like methotrexate, or azathioprine dosage is 1 to 2 mg per kg per day. Okay, methotrexate is up to 20 mg per week. So there is research of TNF alpha inhibitors and or anti-TNF agents, but there is no enough sufficient data to show that they are effective. Okay, So that's about the management. Other aspects of the extraocular symptoms like skin lesions and all requires topical treatment. Uveitis requires ophthalmological evaluation like slit lamp examination and treatment by ophthalmologist. So other things we have to take care. Okay, that's about our treatment of reactive arthritis and its management and clinical features. If you find this video useful, please share among your friends, colleagues. Thank you.